Good morning. Before we start this morning, I just want to say that you will note that neither of the assessors is here today. But I think, as I explained at the beginning of the hearing, if they're not present here, they're following the proceedings using the broadcast and the live transcript, and then they keep in touch with me. Now, Miss Graham, who's the first witness today?
The first witness this morning is Dr Katherine Mitchell.
Good morning, Dr Mitchell.
Good morning.
You're going to be asked questions, but before that, I'll ask you to take the oath. So will you raise your hand, please? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Miss Graham.
Dr Mitchell is going to be taken by Miss Thompson.
Miss Thompson, yes, Miss Thompson.
Good morning, Doctor.
Good morning.
Is your full name Katherine Mitchell?
Catherine Frances Mitchell.
And how old are you, Dr Mitchell?
So I was born in 1980. I'm 42, I think, no? Yes.
Give or take.
42 this year.
42
yes.
on your next birthday.
Yes.
Grand. And what are your professional qualifications?
So I've graduated with an MBCHB, and that was in 2005 from the University of Dundee. And since then I have gained the MRChem, which is a qualification in emergency medicine issued by the Royal College of Emergency Medicine. It's a 3-part examination.
All right. You mentioned the MBCHB. Is
Yes.
that a medical degree from
Yes,
university?
Yes, a Bachelor of Medicine and Surgery.
And the MRChem, what does that stand for?
That's a member of the Royal College of Emergency Medicine.
And you explained that was a 3-part examination.
Yes.
Am I right to understand that in your current role you're a specialist trainee, Year 5 in emergency medicine?
That's correct, yes.
Should we understand then that your specialism is emergency medicine?
Yes.
If I can take you back to May of 2015, at that time you were working within the A&E department at the Victoria Hospital in Kirkcaldy.
Yes.
And I understand that at that point in your career, you were what's called a Foundation Year 2.
Yes.
Can you explain, please, what that actually means?
So, with the current structure of medical training, after you graduate, you work in a foundation programme for 2 years. So I had initially graduated in 2005 and worked in a foundation programme at that point until 2007. And then as I worked in ophthalmology after that. I then had a break while my children were small and returned back into practice, regained those foundation competencies over a course of 3 years part-time, and then was eligible to apply for specialist training, which I've undertaken since 2012. Does that help to answer?
It does. Foundation year might not mean very much to me or to others who are listening to the proceedings, so I thought it would be helpful to ask you to explain. So I think we have a clear idea now of your career progression from university through to 2015 and where you are today. And I think I'm right to understand too that your specialism now certainly is in accident and emergency medicine.
Yes.
I'm going to be asking you some questions about a patient who you saw in the A&E department at the Victoria on the 3rd of May of 2015, a Constable Nicole Short, who had been assaulted at work. Before I ask you any questions, I want to make sure that you've got everything that you need to give your best evidence to hand. And there's a folder in front of you, Doctor. If you open that up,
Yep.
you should find within it a copy of the statement that you gave to the inquiry team. That's got reference 115 on it.
Yes.
And it's a statement that you gave to a member of the inquiry team on the 16th of March of this year. Do you see that?
Yes.
If we could have that on the screen, please. Page 15, paragraph 79. I'll just take you to the end of the statement. It concludes with the words, "I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry, and to be published on the inquiry's website. Do you see that?
I do.
And beneath it, do you see your signature?
So that was explained that it was an electronic signature,
I
and I was
see.
to sign it electronically, which I did.
Grand. And have you in fact signed every page electronically?
I believe so, yes.
You'll see that on the version that's popped up on the screen, your signature has been redacted. But the hard copy in front of you bears your electronic signature.
That's correct.
And also the date, the 16th of May of 2022.
Yes.
Also in the folder, there should be a statement that you gave to the PIRC, that's the Police Independent Review Commissioner, on the 17th of June of 2015. That's got reference 294. So the statement was given on the 17th of June 2015 to a DSI Miles, who was accompanied by a trainee from the PIRC. And you gave that statement at the A&E department. Do you recall giving that statement?
I think I do, yes.
And when you spoke to the PIRC, would you have done your best to tell the truth and give a complete and accurate account of the events of the 3rd of May?
I would have done.
If we can flick back to your inquiry statement momentarily, please. At paragraph 11, please. When you gave your statement to the inquiry, you were referred back to your earlier statement given to the PIRC, and you said, "I've read my previous statement. I gave a true account to PIRC to the best of my recollection and using my notes." Would those be the accident and emergency notes?
Yes.
You don't have a separate
I don't
note?
have any separate notes, no.
Having read it, it doesn't really bring back anything in my memory that I could add on top of what is already written down, unfortunately. And if we scroll down to paragraph 12, please. I would have thought my memory would be better when I gave the statement than it is now. I have been asked if, in the event there is a contradiction between what is in my inquiry statement and what is in my PIRC statement, which statement should be preferred. I'm not an expert, but I would imagine that recollections given closer to the time are more likely to be accurate. So using the initial information in my PIRC statement seems to me to make more sense than using information provided now. So you've been clear that if there is any discrepancy between your inquiry statement and your PIRC statement, we should prefer the PIRC statement because it was given closer in time to the events of May 2015.
I think so, yeah.
Also within the folder there should be the accident and emergency notes for Constable Short. They are PIRC 1158. Perhaps if we could look at the second page very briefly, Mr. Norrie, and scroll down just a little further, just so that we can see your name there, name of Dr.
Yes.
Mitchell, FY2, that's Foundation
Yes.
Year 2,
Correct.
I assume. Time seen 8:20, and sorry if we scroll up just a little bit so that we can see that Constable Short's name also features top right-hand corner, I think. And we see these are the notes that relate to Nicole Short. Now, we don't need to scroll further through the document on the screen, but if you could perhaps cast your eye through those notes and confirm that they are written in your hand.
Yes, they are.
So these are the notes that you took on the 3rd of May of 2015.
Yes.
Can I ask whether you wrote these notes during the consultation with Nicole Short, or did you write them up later on?
I can't remember exactly, but because working in the emergency department in Fife, you can take paper notes rather than typed notes. What I would usually have done, I think, would be to take the card into the cubicle with me and probably write some of the history whilst I was speaking to a patient and then examine them, but probably write up the examination sitting outside of the cubicle after I'd finished.
So it would be your practice then to do a combination of taking the history and writing that up at the time, carrying out the examination and then writing up the rest of your notes retrospectively.
Yes, yeah.
Would they have been written up within a short time of seeing the patient?
So I would always try and write my notes up certainly on the same day, and I would imagine that they were probably completed within quite a short time of seeing her.
May we take it that the notes are true and accurate?
They would have been accurate to the best of my knowledge, yes.
And insofar as you've agreed that your memory was perhaps better in May 2015 than it is today,
Yes.
should we prefer what is written in the notes if it should come to pass that there might be any discrepancies between the note and statements that you've given subsequently?
I think so. They would have been the first things that I wrote down, followed by the perk statement, followed by the statement given to the inquiry. So if there is any discrepancy, as I say, I'm not an expert, but I would imagine what was written down first is probably the most accurate.
Because they were closest in time to your examination of this patient.
Exactly.
So they were written up in all likelihood partly during the consultation and partly later that day, whereas your perk statement was given more than a month later on the 17th of June,
Yes.
and your inquiry statement was given some 7 years after the event. We can take that down from the screen for now. Thank you, Ms. Drury. So I'm going to ask you some questions about Constable Nicole Short. Do you recall this patient at all?
A very vague recollection only of the consultation. As I've said in the statement that I gave, I think she was quite slim build. I think she may have had blonde hair. And I do remember examining her, but all the details I would have to refer to what I've written down previously.
You must see a lot of patients in A&E.
We do.
Can we look then at the medical notes at page 3, and we'll begin with the history. So we see, again, the notes are dated the 3rd of May. They're dated 8/10. The cover sheet was dated 8/20.
I wonder if some of the clocks in the department and the computer screens had slightly different times.
I see.
So I can't explain why one's 8:20 and one's 8:10, but that's a potential explanation.
Can we take it that the clock that was to hand when you took the history said 8:10 on it?
I can't remember exactly.
All right. Mitchell FY2, again, that's yourself. And the first 6 lines or so give a history of the incident. Can I ask you just to read out that history? The first 6 lines are thereby.
Starting with police officer, chased by member of the public this morning, sustained blows to the back of the head, remembers falling and putting arms out to save herself, curled up into a ball and was then lifted by one of colleagues and told to sit in the police van.
Grand. At the very beginning, there's a circle with a cross and 29. What does that mean?
So that would refer to the age of the patient and the fact that she's female.
That's the female gender sign. Is that right? Is it your practice to take the history from the patient?
If I'm able to, it would be my practice to take a history from the patient, yes.
In what circumstances might that not be possible?
So if a patient's unconscious, then they wouldn't be able to give you a history and you might be able to collect information from other people. Or if somebody's very confused, you might get information from other people with their consent if it's necessary and practical to gain that.
Can you recall whether on this occasion the history came from Constable Short or from someone else?
I can't recall, but I can't see any reason why it would have come from somebody else.
And if we look at the history, it includes the words, remembers falling and putting arms out to save herself.
Yes.
Does that tend to suggest that she has shared her recollection of the events with you?
That's how I would interpret that, yes.
Doctor, from a medical perspective, why is it important for you to take a history from a patient?
So a history starts to give you information about why the person has presented to you. It gives you information about what their presenting complaint is, what symptoms they're suffering, and it often helps you to work out the reason for those symptoms. and to focus your examination and then any subsequent investigations that are necessary as well.
So it's an information gathering exercise essentially for you.
Yes.
And in taking a history from a patient, would you be keen to elicit from them what has happened
Yes.
and any injuries that they're aware of
Yes.
and any body parts that might be sore?
Yes.
Now, in the notes, and you have the hard copy before you, please cast your eye over that if it would be helpful. There's no mention of back pain or pain in Constable Short's right-hand side. If she had complained of pain in her back or side when you took the history, would you have made a note of that?
I can't see any reason why I wouldn't have made a note of it.
Would it have been important to you if she had made a complaint of back pain or side pain?
It would have been, because then it would have alerted you to the fact that there was potentially an injury affecting her right-hand side or her back.
Nicole Short has now given evidence, and she described experiencing a searing pain in her right-hand side after the assault. If she had complained of a searing pain in her right-hand side when you examined her, would you have made a note of that?
I don't see any reason why I wouldn't have done.
And again, would that have been important information from your perspective?
Yes.
I'd like to ask you some questions now about your examination of Constable Short, and if we could perhaps go back to your inquiry statement for a moment, please. And again, the relevant paragraph will pop up on the screen. Paragraph 77, please. We can ignore the first sentence for now, but it records that all I can state is my recollection and my notes as I've written them, my recollection to the best of my knowledge and what would have been generally taken to be my examination of a patient who had presented after a history of an assault. If we can scroll down, please. Which would generally be that sort of top-to-toe examination to try and establish whether there were any injuries that were not initially obvious either to the patient or the clinician. So should we understand that in a case such as this, where there's a complaint of an assault, you will carry out what's known as a top-to-toe examination?
Yes, and then focusing on areas where there were particular interest. So the patient had given a history of a head injury, so part of my examination would have focused on whether that head injury was likely to be significant in terms of requiring further investigation. But I think if I look at my examination, I've also examined her chest and her tummy to try and elicit whether there were any injuries in those areas of the body as well.
So was your examination limited to the head, the chest and the tummy, or did you carry out a top-to-toe examination? So
as part of the assessment for a head injury, you're looking at how the nervous system is working. So that also includes looking at the patient's face and examining their face and whether there are any what we call cranial nerve injuries or deficits, and also their arms and legs to make sure that the muscle groups and the sensation in all four limbs are working correctly as well.
All right. Sorry, carry on.
Thank you. I think I've also mentioned that she had some abrasions over her elbows and knees, so had looked at her hands to see if there was any signs of injury there as well.
So were there any parts of the body that weren't examined as part of your top-to-toe examination?
I don't think so, looking at the notes.
And why is a top-to-toe examination important where there's a history of assault?
With any sort of trauma, there can be what we would sometimes term a distracting injury. So an injury which is maybe more severe and more focused on by the patient and maybe the clinician initially. But if there has been trauma, then it's important to establish whether there are any other injuries that have not been apparent initially.
So could a distracting injury potentially mask something of equal importance that's going on?
Yes, but it is maybe presenting a little bit more subtly.
I see. Does the top-to-toe examination, or rather on this occasion, did the top-to-toe examination involve an examination of the torso?
So I've written within my notes that there was no obvious injury to her chest, and noted that percussion was resonant throughout, so that would have involved tapping on her chest to see whether the lung fields were resonant. I've then written vesicular breath sounds throughout, which would have involved listening to the patient's chest and therefore examining her torso.
Now, if we can look at paragraph 50 of your inquiry statement, please. You give a description of what is meant by the chest from your perspective as a doctor, and you say the chest is describing from the bottom of your neck down to the bottom of your rib cage. Your ribs are coming down lower on each side than they do in the middle, and they're providing some protection to your upper abdominal organs. This would include your lungs. Listening to a patient's chest breath sounds would usually involve listening at both the front and the back. So when you say that you carry out an examination of the chest, are you examining the front of the body, the back of the body, or both?
So I can't remember the specifics of this consultation, unfortunately, but you would be examining both the front and the back usually.
That would be your normal practice?
Yes.
And can you think of any reason why you would have deviated from your normal practice in this consultation?
No.
When you examine the chest, do you do that on top of the patient's clothes, or do they require to undress?
So it does depend a little bit on the situation. I know that this patient had people with her when I saw her, and you're obviously aiming to carry out as thorough examination as possible whilst maintaining the patient's dignity. I can't remember whether I asked her to take off her upper clothes or not on this occasion.
Are there any aspects of a chest examination that would require you to look at or touch the patient's skin beneath their clothing?
So I've written, can I just go back to my notes?
Please do.
Thank you. So I've written that she had no chest pain and that there was no obvious injury to the chest. As I said, I can't remember whether that was directly looking at her skin or not. Had she described chest pain, or had I elicited any tenderness when I was examining her by tapping on her chest or listening to her chest, then I would imagine that I would have asked her to take her clothes off so I could look at the skin and see if there was any bruising or marks there.
Now, we know that on the day in question, Constable Short was wearing a protective vest as
Right.
part of her uniform. Do you recall her wearing a protective vest?
Not during the consultation, no.
All right. And if she had been, would you have asked her to take that off?
I don't know the equipment exactly, but I would imagine it would be very difficult to listen to a person's chest through a large vest. So if she was still wearing it, I probably would have asked her to take it off.
I can perhaps help you with that, Doctor. I think we have a demonstration vest in the hearing space. And if Miss Drury can perhaps pass it to you so that you can feel the weight in it and the thickness of it.
Thank you.
Would you have been able to carry out an examination of a chest on top of that vest?
I would have thought not, no.
So if she had been wearing that when she came into your consultation room, would you have asked her to remove it?
I would have imagined so, yes.
Thank you. You can perhaps give that back to Miss Drury. Returning to your inquiry statement, if we could scroll up just a little bit, please, to paragraph 48. My usual practice would be to press and see whether there was actual chest tenderness when you were pressing over the chest wall itself. But again, without having specifically written no chest tenderness, I can't tell you whether that was what I did at the time or not. You mentioned there pressing, and your evidence you spoke about tapping. Are they one and the same thing?
So talk in the notes about percussion, which is a particular part of the chest examination. You place your hand on the patient's chest and tap like this, and you're trying to elicit whether there is a sound of sort of hollowness to indicate that there is air within the lungs, or whether there is a sound of dullness, which might indicate fluid within the lungs, and in the case of trauma that might be blood, or whether there is a sound of what we would term hyperresonance, which would indicate that there's too much air within the chest cavity and a potential pneumothorax, where air is within the pleuritic space rather than the lung itself, and therefore potentially compressing the lung.
So you demonstrated there what you would do when tapping or percussion. You'd put your one hand on the patient's chest.
Yes.
And it was a knocking gesture
And
that
then
you made?
just knocking on your knuckle to try and elicit how air is moving within the chest cavity.
Would you do that to the front of the chest, the back, or both?
Often just the back, but sometimes the front as well, and I can't remember whether it was the front and the back in this case.
But it certainly would have included the back.
Yes.
Returning to your statement at paragraph 49, you explain that your usual practice would be to look at the chest and to press on it, then to listen to the chest as well. I may have asked Constable Short's colleagues to leave, or asked her if she was happy for me to continue with the examination with her colleagues present. I can't remember the detail of the examination. So when you describe their pressing on the chest, is that the same as the percussion or the tapping that you've demonstrated?
So, no, that would be more just pressing to see whether there was tenderness over any of the ribs.
I see. So the tapping or the percussion is to do with the lungs, essentially.
Yes.
And looking to identify whether there were any problems with the lungs. But the pressing is to identify areas of tenderness.
Yes.
Okay. So again, when you said that you would press, you made a gesture against your body. Can you do that again and explain how you would press the chest?
Just pressing gently over the chest wall itself and seeing if the patient is finding that uncomfortable or not. Unfortunately, I've not specifically referenced that in my notes, so I can't say whether I did that on this occasion or not.
Would that be your practice?
Practice varies depending on the situation, and if she hadn't complained of chest pain, then I can't say I would have necessarily done that. If she had complained of chest pain, I would have done. Or unlikely to have done. As I say, I don't want to say anything that's not correct.
So your usual practice, if there had been a complaint of chest pain, certainly would be to press in the way that you've described. And you've said that the chest includes the front of the body and the back. If there had been any complaint of back pain, would you have carried out a similar examination?
And if I can just go back to my notes again. No, I've written that she had no C-spine, so cervical spine tenderness, but I've not documented whether or not she had back pain.
All right, and that there had been a complaint of back pain, is that something that you would have noted?
Yes. Well, I can't see any reason why I wouldn't have done.
So you can't assist us, relying on your memory 7 years after the event, as to whether you pressed to check for tenderness, but you are quite clear that at the very least you would have tapped the back of her chest, or her back, essentially to check for any issue with the lungs. And that tapping that you're demonstrated, do you do that at a particular place on the back, or is it all over the back?
So I would usually do that in 3 places on each side. So in the upper part of the chest on the left. So when I say chest, the back of the chest. So the upper part on the left and the right, then the middle on the left and the right, and the base on the left and the right.
And in your experience, where a person has sustained an injury to the back of the chest or to their back, can that tapping, albeit you're looking, your interest is in checking their lungs, can that process of tapping elicit tenderness where there is an injury?
I would imagine if you're placing your hand and then tapping over it, if there is tenderness, you may elicit it at that point. but you're not pressing in, so you might not.
The tapping that you would have carried out on Constable Short's back, would that have been on the skin or on top of her clothes? Can't you
I'm
say?
afraid I can't remember.
If you had at any time seen her skin and noticed a visible injury, would you have made a note of that?
Again, I can't see any reason why I wouldn't have noted that.
If you'd noted any bruising or redness, would you have noted that?
Again, I don't see any reason why I wouldn't. And in the areas where I had noted redness, such as on her right ear, I've documented that in the notes.
And if we turn to the notes, please, at page 3. A little bit further down the page, please, Miss Drury. You've recorded no chest pain, no obvious injury to the chest. The percussion was resonant throughout, that's the tapping that you've described. Vesicular breath sounds throughout, what does that mean?
So that's listening with a stethoscope to the patient's chest. Again, usually the back and the front, and you're listening to see how air is moving through the lungs to determine whether that is equal on both sides. If it was unequal, then it might suggest an injury to one side of the chest, and whether that air is moving in a normal or vesicular way, or whether there are any added sounds to the breathing, such as crackles or crepitations, or possibly wheeze, as you might hear in an asthmatic patient.
When you use the stethoscope, is that on the skin or on top of the clothes?
Again, I can't remember exactly in this case.
Doctor, can you assist me with this? Where is the kidney area on the body?
So I would say your kidney area is about here.
You're indicating you've put your hand
Just
on
below my rib cage.
below the rib cage
and on the back.
Just above the waist, between the
Yes.
between the bottom of the rib cage and the
And
waist,
the top of your pelvis.
and the top of the pelvis. I want to ask you some questions now about loss of consciousness, and I want to begin by asking you how you would assess for loss of consciousness in a patient who is now conscious, but how,
Yes.
how would you confirm or rule out a history of loss of consciousness?
So I would ask the patient what they remember about the events, and if they can give me a full history of exactly what has happened with no breaks or gaps in their memory, then that would indicate that they haven't lost consciousness. If they have a piece of the recollection that is not clear to them, then that might suggest that they have lost consciousness, or indeed if they just say, I can't remember what happened after this point, then that could indicate that they lost consciousness at that point as well.
All right. If we look at page 5 of the medical notes, please. Sorry, just the top of that page, please. This is a continuation of your notes, and it begins GCS 15 out of 15. What does that mean?
So that's the Glasgow Coma Scale, and it's scored out of 15 points, and 15 out of 15 means that the patient is alert and orientated, their eyes are open spontaneously, that their speech is not confused, and that they are able to obey commands or follow instructions that you give.
What's peril?
So that is an abbreviation used in respect of an examination of a patient's pupils, indicating that each pupil is reactive to light.
You then explain no cranial nerve deficits identified. What's the relevance of that?
So your cranial nerves are the nerves that supply your head and your face. We carry out an examination which includes asking about changes to vision, looking at how the eyes are moving, looking at how the muscles of the face are working, very crudely testing a patient's hearing by making a quiet noise in each ear, asking about sort of speech, or observing speech, and asking whether they've noticed any sort of asymmetry or difficulty swallowing, any changes to the function of their face.
And you recorded no cranial nerve deficits identified, no double vision,
That's correct.
no is CSF cerebral spinal fluid?
Correct, yes.
From the, would that be nose and ears?
Yes.
And what does the absence of cerebral spinal fluid tell you?
So you're looking for whether there is CSF coming from a patient's ears or nose, because it can fit with a base of skull fracture, so a more serious head injury.
So if it was present, it would be a red flag for something more serious. No blood in the ears? What might blood in the ears indicate?
Again, could be an indication of a base of skull fracture.
No Battey's sign, what's that?
Oh, sorry, my writing's not very good there. So no Battle's sign.
Battle's sign.
Battle's sign refers to bruising behind each ear, and again is a sign of a base of skull fracture.
So this is a lady who has given a history of having been struck to the head, and you are looking to rule out the possibility of a more serious head injury, is that?
That's
is that
correct.
And finally, no C-spine tenderness?
So that would likely have involved pressing on the bones of her neck to make sure that there was no tenderness there.
Returning to consciousness, if we can go to your inquiry statement, please, at paragraph 32. You say, one of the parts of my assessment would be, can the patient talk to you and describe what has happened in a coherent way? And she did that. That's confirmed in my notes by the fact I've written she was GCS 15, so alert and orientated. And you said earlier in your evidence that you would be looking for any breaks in the history of events. Were there any breaks or missing parts in the history that Constable Short was able to give to you?
So looking back at my notes, I didn't find that there were any breaks in that history. She was able to describe, well, I've written that she described what had happened prior to the event in the fact that she had been chased, and that she remembered the fall itself and putting her arms out to save herself, and then that she curled up in a ball and was then lifted by one of her colleagues. So I didn't find any breaks in the history when I discussed that with her.
Returning to your inquiry statement at paragraph 33, you say, if she had been hazy in her recollection, it's likely I would have written that down. If there was a bit she couldn't remember, that would have been clinically significant, so it's likely I would have written it down. If she had a hazy or incomplete recollection of events, then I would have been likely to conclude that she may or did have a loss of consciousness. And looking at my notes, I felt she hadn't had lost consciousness. If a patient can recollect all of the events, then it would be normal practice to assume that they hadn't lost consciousness because they can describe everything that happened. If a patient can't recall the 30 minutes before a head injury, this would be a reason to carry out a CT scan of their head. So it's not necessarily the loss of consciousness that's important in terms of your clinical decision making, but also whether there's a lengthy period of amnesia or memory loss before the incident, which wasn't demonstrated to me in this case. What is the significance of a period of amnesia in the 30-minute period leading up to a head injury?
So that's one of the situations where we would carry out a CT scan of a patient's head after a head injury. So there's a number of different indications that are published in guidelines, and if a patient can't remember the 30 minutes before a head injury, I believe there's an association with more serious injury, and therefore the suggestion in the guidelines is that you would be sensible to carry out a CT of the patient's head.
Okay, so it'd be an indication for further investigation.
That's right, yes.
Paragraph 35 of your inquiry statement, You were taken to your PERC statement where you'd recorded, during my examinations of Nicole Short, I was able to discount the loss of consciousness by her ability to recall the events pre and post-event. And you say that if that's what you said a month or two after, that would be an accurate version of events. So should we understand that as far as you're concerned, you were able to discount the possibility of loss of consciousness here?
That's correct.
Can you look please at page 6 of the medical notes? Now, I think on the screen it might be upside down.
No?
Oh, no, just my copy that's upside down. It appears to say question mark LOC, would that be loss of consciousness?
Yes.
Punches to back head. Do you recognise that handwriting?
I'm afraid I don't. No.
So it's not your handwriting?
It's not mine.
Can you assist us as to whose writing it may have been?
But my only suggestion would be it could have been the triage nurse if the patient was taken to triage prior to being seen by myself, which would have been the usual practice within the department. They may have written that there, but I don't know.
But as far as you're concerned, loss of consciousness is something that you considered and you felt able to eliminate.
That's correct.
If Constable Short had lost consciousness at about 7:20 a.m., what impact, if any, would that have had on her presentation when you saw her about an hour later?
So it's difficult to say, but I would imagine that if she had lost consciousness at that point, she wouldn't have been able to tell me what had happened in the events leading up to her presentation, or certainly the events around that time. I don't know what events were taking place at exactly that time, but if she had lost consciousness, I would have expected there to be a gap in the recollection that she gave me.
Is it possible to suffer from concussion without having lost consciousness?
So after an injury to the head, you can get without losing consciousness, you can have symptoms such as feeling a little bit sick, maybe feeling a little bit unsteady, finding that your memory's not as good, or you're very tired, and I believe those would be symptoms of concussion. So I think, yes, you could have symptoms of concussion without loss of consciousness.
So if we were to hear that Constable Short was subsequently diagnosed with post-concussion syndrome, that wouldn't undermine your assessment at the time that she hadn't suffered a loss of consciousness?
I think you'd have to ask a medical expert about that.
If we can return to the medical notes, page 4 of the notes, please. And the bottom of that page, please, Mr. Norrie. So having taken the history and conducted the examination of the patient, you've recorded your impression, which was head injury, no neurological deficit identified, no bony injury identified, and the plan, discharge with head injury advised to stay with someone today overnight.
That's right.
Is that standard advice where a patient may have suffered a head injury?
Yes. So after a head injury, we're trying to ascertain whether there is any evidence of a serious head injury that would require further investigation or observation at the time, but there is recognition that some of these symptoms can develop after a consultation, and therefore we advise patients to stay with someone for 24 hours after a head injury and to represent should certain symptoms occur or if they have further concerns.
Doctor, I want to return to your consultation with Constable Short, and I asked you lots of questions about what she was wearing, whether she undressed, and perhaps unsurprisingly, 7 years down the line, you don't recall. I am, however, reminded that when Constable Short gave evidence on the 24th of May to this inquiry, She said, I was given a gown to put on, a hospital gown to put on. Now, tell me about hospital gowns. When a patient is asked to put on a hospital gown, would the expectation be that they take off their day clothes and just wear the gown?
I think so, yes.
And what's the purpose of a patient putting on a hospital gown?
It would potentially make your examination more easier, because it's a little bit like at the hairdresser when you're asked to put a gown on over your front and the back is open. So it could make your examination easier.
So the back of the gown is open?
Usually, yes.
And if the back of the gown were open, then you would be able to see the back of the chest more easily?
Yes.
And if Constable Short had been wearing a gown that was open at the back, can you comment on whether it would have been more or less likely that your examination would have been performed on the skin?
I suppose it's probably more likely, but I honestly can't remember those details.
All right. I want to move on to ask you about another issue now, Doctor. There is evidence before the chair that the man who assaulted Nicole Short stamped on her back. Now, she does not recall this, but was told about it after she returned to the police station following her visit to A&E. 2 police officers have given evidence that they saw the man stamp on her back. A civilian eyewitness to the incident says it did not happen, so you'll appreciate it's a contentious issue. And the chair to the inquiry will require to make a finding in due course as to whether the man stamped on Constable Short. If he did, where on her body, how many times, and with what degree of force. And it may assist the chair to know what the medical evidence tells us. And as you may be aware, you were the first doctor to examine her after the assault. I'd like to give you descriptions of the stamp, the descriptions that have been provided by the 2 officers who say that it happened. And it may be that we can bring these up on the screen. If not, I'll read them out. Ms. Drury, do we have Perk 263, which is Constable Tomlinson's statement? If we can go to page 3, paragraph 3, please. Scroll down. I'm sorry, it appears that I must have the wrong page reference, but not to worry, I'll simply read out what I'd hoped this would say. He stomped on her back with his foot with a great deal of force. He put his full body weight into the stomp and used his arms to gain leverage. After he did this, she went back to the floor and never moved. I thought he had killed her. He stomped on her back again with the same force, and she wasn't moving. So that's the description provided by Constable Tomlinson in his statement to the Perk. And I'd like to give you a similar description provided by Constable Walker, and again I'll just read this out. But this is from a statement he gave to the inquiry. PC Short was lying face down in the prone position on the road. Shekubayo was standing at right angles to her. I saw him with his right leg in a high raised position. He had his arms raised up at right angles to his body and brought his right foot down in a full force stamp down onto her lower back, the kidney area. So those were the descriptions given by the officers. And when they gave their evidence, they were asked to demonstrate the stamp. And I'm going to ask you to watch their demonstrations because the evidence was, of course, recorded. So if we could perhaps watch Constable Tomlinson's demonstration first. Please.
Thank you.
And now Constable Walker's demonstration.
Up like that. So bent at the elbows. And if you could now demonstrate his right leg in a high raised position. Thank you. And then he brought his right foot down in a full force stamp, and I'd like you to demonstrate the force that he used, if you can.
Okay, so you've heard the verbal descriptions and you've seen the demonstrations that were given in evidence. Now, Doctor, I'm going to ask you some questions about that, and if you feel that these questions take you out of your field of expertise, then please just tell me. But would you have expected a stamp or stamps as demonstrated there to have caused injury?
I think you probably are taking me a little bit out of my field of expertise for a proceeding such as this, and maybe a sort of forensic expert might be more appropriate to provide a more definitive answer. But on the first page of my medical notes, I have written that the patient's abdomen was SNT, which is soft and non-tender, and that there was no obvious abdominal injury and no abdominal pain. That would have involved pressing on the front of the patient's tummy, putting one hand underneath and then sort of squeezing the kidney area between two hands to see if it elicited any tenderness.
Squeezing the kidney area?
So the flank, yes.
And had there been any tenderness, would you have made a record?
I don't see any
of
reason
that?
why I wouldn't have done.
All right. Can you bear with me a second, please? I have no further questions for you. Thank you, sir.
Thank you. Are there any Rule 9 applications for this witness? Miss Mitchell. Dr. Mitchell, would you mind going back to the witness room while I hear a submission?
Of course.
Yes, Miss Mitchell.
Just one issue. In the inquiry statement given by Nicole Short at paragraphs 23 and 24, she indicates that she told the doctor, that being Dr Mitchell, oh sorry, I should say for the record that's inquiry statement of Nicole Short, it's number 41. At paragraphs 23 and 24. At paragraphs 23, the last sentence, it says, when she was being examined by Dr Mitchell, I told the doctor at the time I knew I wasn't speaking normally, but she discounted that for some reason. And then at 24, I do remember telling Dr Mitchell that I felt I wasn't speaking right, and her replying that I sounded all right to her. Now, we've also heard evidence given by this witness that in terms of the Glasgow Coma Scale, one of the things that she assesses is speech. And what I would like to know from this witness was, if Nicole Short mentioned to her that she was not speaking normally, would this have been important? Would she have written it down? Would this have been significant? And what further steps might she have taken?
Yes, very well. I'll allow you to ask that. If you can rearrange the seats. And can we have the witness back, please? Dr. Mitchell, Miss Mitchell, who's the Senior Counsel for the Bio family, has a question for you.
Of course. Hello. Good morning.
Good morning. Just one issue that I want to ask you about, and that is you've explained to us this morning as part of the Glasgow Coma Scale, one of the things that you assess is speech. Can you explain to us what that is, what you carry out?
So really just through your talking to the patient to make sure that their speech is orientated, that they can describe events, that they don't appear to be confused in any way, or indeed that speech has got a sort of unusual or slurred quality to it. My notes indicate that when I examined the patient, she was not confused and that her speech was normal.
If Nicole Short mentioned to you that she wasn't speaking normally, would that have been clinically significant to you?
So I don't see any reason why I wouldn't have noted that down, and it may have then been a reason to carry out further investigation.
Why would it have been significant?
So if she felt her speech was abnormal, then it may have indicated an underlying brain injury, which might require a CT scan, or it could have indicated an injury to another part of the body that's involved in conducting your speech, such as your face and your mouth, your lips or your tongue.
Can you imagine, would there be any circumstance if Nicole Short said to you that she wasn't speaking normally, you saying that that Nicole Short sounded all right to you and not writing that down?
I can't remember the exact details of the conversation, but I can't imagine why I wouldn't have noted down if she felt her speech wasn't normal.
And you may have taken further steps if that were so?
Possibly, yes.
Dr Mitchell, thank you very much for coming to give evidence to the inquiry. The inquiry is going to adjourn in a moment and then you'll be free to go. Now the next witness, Miss Graham, is going to give evidence remotely.
That's correct.
So what we'll do, I think, is adjourn for 20 minutes and take an early break in order to make the arrangements for the witness to give evidence remotely.
Thank you.
Now, Miss Graham, who's the next witness?
Next witness is Dr Gillian Norrie, and she's joining us remotely, so we can now see her on the screen.
Good morning, Dr Norrie. Can you see and hear me? Dr Norrie? I'll try again. Dr Norrie, can you hear me?
Yes, I can hear you now.
Thank you. And can you see me?
Yes, I can.
That's fine, thank you. Well, good morning. You're going to give your evidence, as we know, remotely. You'll be asked questions by Ms Graham, who's the senior counsel to the inquiry. Before that, I wonder if you would say the words of the affirmation after me. I solemnly, sincerely and truly
I solemnly and sincerely and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Now, the next face that you'll see is Miss Graham, and she'll ask you the questions.
Okay.
Miss Graham.
Thank you. Good morning, Dr Norrie. I'm Angela Graham.
Good morning.
Your name is Gillian Norrie, is that correct?
It is
What age are you, Dr Norrie?
50.
And we have all of your contact details, so I'm not going to ask you to repeat that.
Okay.
I'm going to be asking you about the 3rd of May 2015. And you're here to help the inquiry today because on the 3rd of May 2015, as I understand it, you were working as a forensic medical examiner at Kirkcaldy Police Office, and that was a role that you'd been doing since the September 2014. Is that correct?
That's correct.
And could you explain to the people listening what a forensic medical examiner does?
Okay. So a forensic medical examiner is an independent doctor who assists the police. Usually it's to aid gaining forensic evidence. So if there has been a situation where a case may go to court, then I am involved in examining either victims or accused to document injuries and obtain forensic sampling.
You've told us in your statement to the inquiry that you did many sexual assault allegations and you were commonly involved in that type of work.
Yes, that is the most common reason that I was called while working as an FME. However, sometimes you were called to road traffic accidents to assess fitness to drive and take samples for toxicology. Or occasionally you may be called to assist an individual in custody who became unwell, who had complex medical needs. But yes, sexual assault was a big part of the job.
Thank you. Now, there are 3 statements I'd like to refer to first of all. Now, I don't know, as you're remote, you may not have hard copies. Do you have those hard copies? You do, I hope.
I think I might have two.
Well, let me go through
I do
them.
have a folder. Yeah, I have a folder
Excellent.
of information.
That's excellent news. Well, the first statement I'd like to refer you to is one dated the 3rd of June 2015, and this was given at 14:35 hours. Now we'll see that here on the screen. You may also see it on your screen, but you should have the hard copy of that as well.
Yes, I have that.
Perfect. So this is a statement that you gave to PERC on the 3rd of June 2015 at 14:35, and it was taken by DC Gillian and DC Muir at St Leonard's Police Station in Edinburgh. Is that the one that you have?
It is.
And am I right in saying that you gave that statement on that day, and that it would have been read over to you, or you would have had a chance to look through it and then maybe sign it?
Yes, that's correct.
And you could have confirmed you were happy with it, or you could have said you wanted to make changes?
Yes.
Thank you. And were you doing your best at that time to give a true and accurate account of what you had done on the 3rd of May 2015?
I was.
And was your statement at that time given to the best of your memory?
It was.
So if there's any differences between subsequent statements or your evidence to the chair today, should the chair prefer this statement?
Yes.
And then the second statement I'd like you to look at, please, is dated the 22nd of January 2018. So this was nearly 3 years after the events. Again given at St Leonard's Police Station by investigator Neil Robertson. Do you see that one?
Yes, I have that.
And I know that you have some comments to make about this statement, and I'll come to those shortly. And we'll deal
Okay.
with that during the course of your evidence.
Okay.
And then the third thing I'd like you to have a look at is a statement you gave to the inquiry, so SBPI 88. And that's dated the 22nd of March this year. Do you
Yes,
have?
I have that, yeah.
And again, you've signed that.
Yes, I have.
And if we look at paragraph 110, so that's on the last page.
Uh-huh.
It says, I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website. And then although we can't see your actual signature, we can see it's been redacted on the screen, but it was dated the 10th of May this year.
Yes, that's right.
And so you've in giving this statement, you've done your best again to give a true and accurate record of your involvement in these events.
That's correct.
Thank you very much. Well, first of all, I'd like to look at the inquiry statement, which is on the screen, but you have your copy. And if there's anything I'm not referring to you want to mention, please just let us know and we can get that put on the screen as well.
Okay.
So you've told us about your role in May 2015 as an FME. Can I ask you to look at paragraph 11, first of all, of your inquiry statement?
Okay.
And you've said here that it was unusual for you to be asked to become involved with the police, and you hadn't been asked to do that previously. In examining police officers, I should say. And then can we look at paragraph 21 as well? And you say it was very unusual for me to be asked to go along and examine police. So I said, I'm not sure that's something that I should be doing, and I want to check with my boss. So I phoned the clinical lead and asked her about it, and she said, yeah, I'm not sure. It does sound quite unusual, but I would go along. there's going to be a PERC inquiry, you need to just go along and do it. And you made your way across to Kirkcaldy. So you weren't based in Kirkcaldy at that time?
No, so there are only 2 doctors on call at any time. But when I was working there in the forensic service, and we shared the workload, generally I covered Edinburgh and down towards Borders area. However, sometimes I did go across to Fife if needs be. So I can only assume that the job was allocated to me because the other doctor on call was already engaged in other work. So it could sometimes happen that I went across to Fife.
Thank you. So you'd be on call and you'd receive a call and you would then travel to the relevant police office to conduct whatever
Yes.
was required?
Yes, or the sexual assault centre, where we would do an examination. If, for instance, it was a sexual assault, they didn't take place in police stations. There was an independent clinical area that they were done.
They would
But
be done in
sometimes
a separate
to police
suite.
stations. Yeah.
And prior to giving this inquiry statement that we could see on the screen here, I understand that the inquiry team sent you copies of medical records to allow you to look at them, relating to officers that you examined that day. Is that correct?
Yeah, that was done via an internet electronic viewing of that, yes.
And you've detailed that in paragraph 13 of your statement.
That's correct.
Thank you. And then if we could look at paragraphs 31 and 32. You say that you were accompanied by a nurse, a female nurse, and you don't remember her name, but she assisted you during your examination of the officers.
That's my recollection. It was a long time ago, but there was a forensic nurse present at some stage. I'm not sure if she stayed for the duration, but at some point there was someone assisting me.
Thank you. And you've also said at paragraph 32 that she wrote down some details to speed up the process, names, dates of birth and addresses. And so some of the writing in the notes is hers in relation to the preliminary details, but the rest of the writing in the notes is yours.
That's right.
Thank you. And then can we look at paragraph 14, please? And you say, having looked at them, you're happy with the notes. You think generally all of them are yours, with your signature at the bottom. They are a true and accurate record of what happened at the examination. And you also told PERC the truth in your 2 interviews. And that's your position to the inquiry. That the records.
That's correct.
Thank you. Now, subject to a few points that you've mentioned and detailed in your inquiry statement, that remains the position.
It does.
But
yes.
let me just look at the areas where you weren't as comfortable, and I think there are 4 areas, and I'd like the chair to be made aware of those, so that he gets a complete picture of your understanding. So if we look first of all at paragraph 15, now this relates to this is the second statement that you gave, the one on the 22nd of January 2018, which was nearly 3 years later after these events. And you've said in that, at the bottom of page 2 of that statement, it's quoted in paragraph 15, the history that she provided prior to my examination concerning this contained in was provided to her by a colleague. I don't know what that sentence means. Obviously, I speak to individuals. That's all part of the examination. We don't just bring a patient in and physically examine them. We have to speak to them and obviously gain information, gain the history, and then sometimes that helps you direct your examination. I've been asked if I would adopt this part of the statement. no, that's not something that I would have intended to say. I don't know why it was written like that. It doesn't make sense. How would I know it was provided to her by a colleague? And so you've clearly explained your view on that passage within that statement to PERC on the 22nd of January. Is that correct?
Yeah.
Because the sentence doesn't really read as if it makes
No.
sense.
Yeah, it's quite ambiguous. It's not clear. I just can't follow what was said. It doesn't make a lot of sense to me.
But when you examined any officer, you would come in and you would speak to them, and you talk about directing your examination. What do you mean by that?
It's very helpful to get some background from a patient so that you can better focus on where potential injuries may be. However, that's not to say that you would only look at that area. We have to adopt a very systematic approach and look everywhere, but it is very helpful to have some background so that if I do find an injury, it makes me think about, does that tie up with what happened? How did they obtain that injury? Obviously, individuals can have obtained injuries prior to events, and have sort of older injuries as well sometimes. So it can just make it a bit more focused if I know some background.
Is it fair to say that you want to be thorough, but
Yes.
you also want to focus on any immediate concerns that the patient themselves have?
That's correct.
Thank you. Could we look at paragraph 16? We have that on the screen at the moment, and we're still reviewing your PERC statement of the 22nd of January 2018. At the top of page 2, at the time I conducted the examination of the officers, I was a force medical examiner. I no longer carry out that role as of November 2015. I'm now working as a locum general practitioner covering all of Edinburgh. That's wrong. I stopped working there in 2017, 2 years later. It's just a typo, just to be correct. When you do locum general practice, you're not on call for the whole of Edinburgh. I work in a few practices in Edinburgh. I'm a GP who's self-employed, I'm a senior GP, I'm fully qualified, and I work for NHS Lothian on a self-employed basis, usually at 2 or 3 regular practices in Edinburgh. So again, that's a mistake in that statement, and you wish that to be corrected.
Yes.
Thank you. And can we move on to paragraph 17? And it says at the bottom of page 2, that's the PERC statement, amnesia is a strange term. It's not something that I would generally write. I would usually say she didn't appear to be confused given the fact that she was orientated in time, place and person. But maybe I did say amnesia. Maybe the police specifically asked me that. I'm happy to leave that. So I just wanted to ask you about this. When you were giving your statement to PERC in January 2018, was it in response to questions that were being asked by the officers or the investigators?
Yeah, I mean, all of this is quite some time ago, but yes.
So is it possible that it was the police, as you say, specifically asked you about amnesia rather than a word that you volunteered?
Yes.
Right. Happy to leave that, but subject to that slight caveat.
I would agree.
And then finally, paragraph 27, please. I have been asked whether, when Jane Combe contacted me, I was to be involved on a welfare basis or a forensic basis. I can't say. I think probably in my previous statement on the 22nd of January 2019, I think we're talking about a statement on the 22nd of January 2018. One part is not entire accurate at page 2. P.I. Combe, I think, provided me with the history of the incident involving the officers. If I was being pedantic, I contacted the forensic nurse who then informed me, so I don't think I did speak with her directly. Now, can I just be clear? We've got the nurse who accompanied you in the examinations. And we've got PI Jane Coombe, who's a female inspector. When you say, I contacted the forensic nurse who then informed me, so I don't think I did speak with her directly, who are you talking about speaking with directly?
DI Combe. I didn't actually speak with her directly. That information was given to me second-hand by the coordinating nurse for the forensic service who was allocating the job.
Right. So there was a nurse who made the call to you to allocate the work to you. And that's who
right.
you spoke with.
That's correct.
And you didn't
And she-
ever actually speak to Police Inspector Combe.
No, I had no interaction with her directly.
So whatever information is there, it didn't come from Jane Combe.
No, that was given second-hand to me.
Thank you. So you've talked to us about receiving the phone call. Could you look at paragraph 18, please? So you tell the chair there that you received the phone call, you accepted the work, and you've also told us a nurse was with you. And I think in another paragraph you say there was no specific order in which you were asked to examine the police officers at Kirkcaldy Police Office.
So is that paragraph 18 or page 18?
Paragraph 18. I'll refer to paragraphs.
Okay.
And we'll have the paragraphs come up on the screen. It makes it easier for us to see things.
Yeah.
And then there's also paragraph 23. And you talk about the nurse.
That's right. That was a nurse that was present in the police station at Kirkcaldy when I
Yes.
arrived.
That's lovely.
So, yeah.
And then can I ask you to look at paragraph 26? And you say there, I had all the written notes and then the next day, so that it was still fresh in my mind. I generally do the dictation as quick as possible. I dictated all of those cases, dropped it off with the secretary at the Orchard Clinic. It was typed up and then checked by me a few days later. Whenever the secretary had done the dictation, that was it. And is that was your normal practice in May 2015 regarding preparation of the notes?
Yes, it's always a good idea to do the dictation, the formal report, as soon as possible. I wouldn't leave a long time between examinations and compiling the formal report. So yeah, that's the normal process for me.
So you've talked about written notes and you've talked about dictation. Can you explain the sequence of events when you are preparing these notes?
So I take the written notes at the time of the examination. They're documenting history and examination findings.
Are those the handwritten notes?
They're handwritten, but a formal report is compiled thereafter. And that's what I'm talking about with the dictation of my findings from the written notes.
Thank you. Could we look at paragraph 35, please, and 36? And you'll see that paragraph 35, I'm going to be asking you questions about PC Nicole Short, not all of the examinations you conducted. And you say you can't remember how long I spent with PC Nicole Short. I'd have to look on my notes. I don't know if I put times on for everyone. I actually think I worked late. I was only on call for a certain time, so I was being efficient. So I may have missed the times in and out, and there was such a lot of examinations. Having reflected on that now, do you have any sense of how long you spent with PC Nicole Short?
I think it was 25 minutes, because when I actually was allowed to view my written notes, the times are documented.
So you were you had actually taken the time to document the times
Yes.
in and out. And
Yes.
then, can we look at paragraph 36, please? Do we see that you've also been shown your notes, and there was a forensic examination record prepared, and you've given us the times there?
Yes.
I'd like
That's
to look
correct.
at PERC 01301, please. And we'll look at the start of this. Page 3, I think. This is it. And you will see there that this is headed up the forensic examination record for Nicole Short, born 1986. And the date of examination is the 3rd of May 2015. And the time of examination is 15:45 at Kirkcaldy. And it ends at 16:10. And
Yes.
were those the entries that you said the nurse completed? Or is that your
I
handwriting?
think that's my hand. If I can have a quick look again, I think it's my handwriting.
Right. And then can we go further down the page, please? It says officer requesting Inspector Jane Combe. Reason for examination, assault in line of duty. And is this all your handwriting?
It is.
And we see that the word history appears, and it says called to incident 7:15 a.m. Black man chasing cars, that's put in apostrophes. When arrived, 2 colleagues spraying. And then it say Nicole's colleague sprayed, then Nicole took baton out but ran away as was chased. She was hit on head with fists, fell forward, 2 hands on ground, then back stamped on. Colleague arrived and I can't read the next word, sorry.
I can't see it. You'd have to put it on the screen for me. I don't have it in the folder.
Right. And anyway, it says something to van, and then
and took to van, I think.
took
to safety.
to van to safety, and then to A&E to check up, observe, and analgesia. And then you've put in capital letters, incident, individual restrained and died. So that was a history. Who provided that history at that time?
Nicole Short.
And it says there, then back stamped on. So there's a mention of her back having been stamped on. Do you see that in your writing?
I can't view it. You have to put it up for me, thanks.
All right. Do you not have a hard copy?
I
of
don't
this?
have that. I don't have
All
any
right.
of my actual original medical notes in
Well,
the folder.
That's absolutely fine. I can read things out. Now, as we move on to page 4, so if we can move down the screen, please. Keep going, please. And then there's on page 4, you've detailed the injuries. Are these the injuries that you noted at the time during your examination?
They are.
And I won't go through those in detail. There's no mention of back there. So it says right knee, and left hand. All right? And then if we can look at page 5, it reads tender right occipital area and right mastoid, no injuries noted, but tender on palpation. And then tender right cervical spine, no injuries seen. And then there's a GMC number at the bottom.
Yeah, that's my registration.
That was your registration. So there was no reference in in those notes of your examination of an injury having been noted by you to her back.
That's correct.
Right. And does that mean that you didn't see or find an injury to her back?
Yes.
Yes. And can you tell us how your examination was conducted, please? What's your normal
Okay,
practice?
Normal practice is to take some vital signs, some observations, so blood pressure, temperature, things like that, heart rate. Obviously, obtain consent first, and then conduct a general physical examination, which would entail checking their understanding, their neurological status, certainly if there was a head injury, listening to their chest, listening to their heart and lungs, feeling their abdomen. And then in terms of the injuries, what we do is a very systematic approach. So we'll start from the head and work down to the feet, and looking at the surface area and documenting any injuries that are found.
We've heard the phrase that doctors do a top-to-toe examination. Is that what you're describing when you say the head to the feet?
That's right.
And can you confirm if you examined Nicole Short's back?
I did.
Did you examine it as far as her lower back into her kidney area?
Yes, I did, as I say, a top-to-toe examination. So I worked systematically down from the head to the bottom of her body to her feet.
Had you found any injury, bruising, marks, discomfort, tenderness? Is that something that you would have noted?
Yes.
If PC Short had complained of pain in a particular area of her body, including her back or to her right side, is that something that you would have noted?
It is. That was the purpose of my being there, to document the injuries. So yes.
Thank you. Can I ask you to look again at your inquiry statement, paragraph 55? And you were asked about your examination of PC Short, and you say sometimes you could give the Glasgow Coma Scale, but that's not something that routinely we would do for observations unless there was concerns about her neurological status. What do you mean when you say concerns about her neurological status?
If I was worried about her how she was neurologically, so if she was presenting after being hit in the head in a way that gave concern, so such as behaviourally, if she was irritable or inappropriate, disinhibited, or if she was drowsy, things like that would obviously prompt me more to look at the GCS, to document the GCS. But her GCS was 15. It was 15 out of 15. There was no concern about her neurological status when I saw. I do recall that.
Thank you. And I'm correct in understanding that 15 out of 15 is normal.
That's correct.
If you had seen any changes in her speech or the way she was speaking, is that something you would have noticed or noted?
Absolutely.
Were there any signs at that stage when you saw her that she had suffered a loss of consciousness?
I mean, that's a very difficult one to answer. I'm not sure I could really say one way or another. Sometimes individuals can lose consciousness and then be fully conscious when you see them. So there's nothing really subsequently that would be obvious to correlate both of those things. But I can say that I didn't have concerns about her neurologically when I saw her. Couldn't say with certainty she had had an episode of loss of consciousness.
There was nothing at that.
Makes sense.
Yes, there was nothing at that time that you noted that gave you any cause for concern?
There was nothing.
Thank you. Can we look at paragraph 58, please? You've been asked about her chest, and you say this is just shorthand for examining her respiratory system. That's really looking at the lungs, listening to the lungs. I'm just saying that it's clear, there's no crackles, and there's no reduced air entry, which might indicate things like a collapsed lung. So that's a normal respiratory examination.
It is, yes.
And when you check someone's lungs, are you checking the front of their chest or their back of the chest, or both?
Both of those things.
So what people such as myself would commonly call your back, you're actually looking at her back?
Yes. It's often referred to as chest examination when you're listening in the back, listening to the lung fields, yes.
Thank you. And would you please look at paragraph 60? You say you can't examine the chest over clothes, you wouldn't be able to hear properly. I mean, I don't remember specifically, but I can't do a respiratory examination through clothes. I would have lifted her top and listened to her chest. And is that your recollection of what you did that day?
Yes, it is.
So could you see her skin at that point?
Absolutely.
And again, if you'd noted any marks or injuries or tenderness or discomfort, is that something you would have noted?
It is, but it's better to do the physical examination first and then be more thorough to then do the actual head-to-toe documentation of injury afterwards. So yes, I may have listened to her chest and be listening to the breath sounds and things like that. If she'd have said, oh, that hurts, I'm uncomfortable there, I'd be aware of it. But that'd be unusual to try and combine both. We would usually split it up to do physical examination, as I said, and then document injuries afterwards.
Right. So physical and injuries, you look externally and listen internally as part of your examination.
Yeah, so you do a physical examination, as I say, sort of with your stethoscope and feeling for things in the lung and the chest and the abdomen, whatever you're doing. But then do a separate systematic approach to the documentation of the injuries thereafter. Otherwise, it becomes messy. It's difficult to make good notes if you try and combine both.
Thank you. Can we look at the paragraph just above, number 59? It says CVS, that's the cardiovascular system. That was just the heart sounds are normal. There's no evidence of murmur. Her abdomen was soft and non-tender. There were no masses there, so no lumps anywhere. But again, a normal examination of the abdomen. Can you explain exactly what you mean when you say abdomen?
An abdominal examination is looking at examining the area below the diaphragm, so below the chest, down to the pubic area. So you're feeling it, making sure that it feels normal, it feels soft, and listening with your stethoscope as well. So it's just doing the routine abdominal examination.
Thank you. Does that include your sides as well, what I would consider my left side or my right side, or is it only at the front?
I think if you're referring to feeling into the kidney area there, I don't think I specifically examined her kidney. I can't say one way or another. It doesn't always.
And would you have asked her to lift or remove her clothing in order to complete this examination?
Yes.
Thank you. Could we look at paragraph 63? And you say, I'd look for injuries after, but I would need to listen to her back anyway to do her chest examination. So if there were injuries, I would see them. Then I would specifically look for it in the next part as well. This is to better document the examination because it's going to confuse things. I have to have a systematic approach. I want to get the physical out of the way and then do the injuries next. So does that mean the top to toe examination and then look for specific injuries if there's a complaint of those?
So the top to toe examination is the physical examination. You're looking at the surface area of the skin and documenting the injuries as you go.
Thank you. Can we look at paragraph 64, please? And you'll see that the medical records at 01301 are actually listed here by you. So you have in your inquiry statement a record of what is contained in the report. Do you see that?
Yes.
And then you continue to discuss those injuries up to paragraph 74. So you will have the hard copy of your inquiry statement, and we could maybe go through those just to look at those briefly. So if we could scroll through to paragraph 74. And can I just say, are you content that those paragraphs 64 to 74 contain what you want to say about those entries about the injuries?
Yes.
Thank you. Can we look at paragraph 75? You've been specifically asked about injuries to the back or rib cage. And 75 says, I've been asked if there are any notes of tenderness of the back or the rib cage. There are none at all. I don't document all negative findings. There's nothing in the shoulder, there's nothing in the loin. You're documenting injuries. That's where the injuries are felt or seen. I have been asked to comment on the position that I was seeing a patient whose back was said to have been stamped on, and I have not made any notes about any injuries relating to that. The feeling of that is because there's none. I've documented the injuries that I have found. So can I just be clear? You are looking for injuries, and if you see any, you document them in your notes.
That's correct.
And you're also listening to the patient. So if they complain of pain or discomfort or having been injured in a particular area, you also note that.
Yeah, so I'm looking and I'm feeling for tenderness.
And if you find that tenderness, you are going to note that down in your records.
That's correct.
And even if you didn't find it, if someone complained of it, if the patient complained of it, you would also note that down.
I would. And if I can just clarify that although we get the background history to help better direct the examination, I'm still doing a thorough examination because an individual might not be aware they've actually been hurt in a certain place. Sometimes that just becomes evident a bit later on. So I'm examining thoroughly and feeling down the back to make sure that there are no areas of injury.
Thank you. So you're not just relying on the patient, you're also checking that independently yourself.
Absolutely.
And in this particular record and in this particular examination of PC Short, there were no injuries noted in relation to her back or her abdomen or in that general area.
That's correct.
Thank you.
At that time, when I saw her, there was nothing to document in terms of injuries in those areas.
Thank you. And then paragraph 76, you say, I can't say with absolute certainty, but my feeling is that I would have felt around all those areas, especially given the fact that she told me that she was stamped on in her back. That's the whole reason why I'm asking that history. I'm not a police officer. I'm not taking the history because it's my job to find out the rights and wrongs of that. The reason is I want to know what her involvement was in the incident to best direct my examination. I have to assume that I have felt all of her areas. I'm just documenting the positives that I've found. And is that your feeling today?
It is.
Right. So you're there to do your job, and the reason for taking the history and doing the examination is to note any injuries that she may have sustained that day.
Absolutely. I mean, that's my role. That's why I was there. So, yes.
Thank you. And then can we look please at, for completeness, PERC 01310. And if we can look at the first page. And do you recognise this? Can you see that on the screen? It's a forensic medical report on PC Short, Nicole Short.
Yeah, I don't have that in the folder, but I can look at it on the screen.
Thank you. It's really just to confirm that this is the report that you described dictating at least the next day or within a few days.
That's correct. That's the report.
And I think in your statement, paragraph 79, you say it was dictated, or it may have been dictated on the 7th of May, and we see at the top of the screen that the date given is the 7th of May.
Okay. That may be the date it was typed.
Right. And can that differ from the day that you've dictated it?
Yes.
And could you explain why?
I'm not entirely sure if that's the secretary's date when she did it, or that's the date that I dictated it, because clearly I have seen the patient before that on the original handwritten notes. I think that's the date that the secretary types it.
And can there be a number of days between you dictating it and giving the tape to your secretary for transcription?
Yeah, theoretically that's possible, but as I say, I think the dates do correlate very closely to one another. The date it was typed and the date that I saw the patient. But yeah, it's up to the FME when they do their dictation. As I said earlier, I like to get it done, but while it's all fresh in my memory.
But in any event, it's based on your recollection, your memory, and your notes taken at the time.
Yeah, it's basically the notes that you're dictating.
Thank you. Can I ask you to go back to your inquiry statement, please? Paragraph 80. And we'll just get that on the screen now. You say you've been referred to page 3 of the report on the instructions of Chief Inspector Conrad Trickett, and I've been asked if he was the senior officer I referred to earlier in my statement as being present on my arrival at Kirkcaldy Police Station. I think so. So earlier in your statement you mentioned arriving at Kirkcaldy Police Office and meeting with a senior officer. And in the report that we've just looked at, you mentioned the name Conrad Trickett. Can you tell us when you arrived at Kirkcaldy Police Office, how you were briefed on what your job was to be that day? And who did that? Was it Mr. Chief Inspector Trickett?
To be perfectly honest with you, it was such a long time ago, and obviously I may not have documented the whole process of actually getting out my car and getting into the station and who met me and so on. My recollection is that I arrived and was met by an officer and taken through to the area where I was to conduct the examinations. And then the senior officer, who I think was the Chief Inspector Conrad Trickett, I've obviously got his name, just basically it was an introduction, a sort of thanks for coming. But I don't think I got any background from him.
All right, thank you.
I don't think that's documented, and I don't recall getting any more information from him, other than just acknowledging I had arrived and thanking me for coming.
Thank you. Can we look at paragraph 84 of your inquiry statement? You say, I've been referred to my report at page 4. That's the report we just looked at. And you're referring to Nicole Short, and you say she was composed and behaved appropriately throughout. She'd had a head injury, so I have concerns and have to think when I'm looking and speaking to an individual. Are they displaying any signs that would lead me to be concerned about them, and that can obviously manifest by speech, how people are, how people behave. People often have received a head injury and are behaving quite erratically, where that's been missed and terrible things happen. So her behaviour was appropriate, her manner would have been appropriate, how she spoke would have been appropriate. It didn't indicate to me that I had any concerns about her neurological status. That's what I'm saying there. And that's something that you comment on in the report that we just looked at.
Yeah, absolutely. I mean, there was obviously I had been told that she had been hit in the head, and she had gone to the A&E with a head injury. So that's something that it's important when I'm examining that individual to bear in mind.
And you're looking out for that?
I am.
Thank you. Can we look at paragraph 87, please? You say, I am qualified to comment on bruising that can evolve over time. I have been asked what I would say about potential bruising in a person whose back has been stamped on, possibly several times. I'm not an expert in that. I don't feel I can comment on that, but certainly I haven't documented any tenderness there. Now, you say that you're qualified to comment on bruising that can evolve over time, and I'd be very interested if you could share share an explanation of how bruising evolves over time.
So what bruising is bleeding after trauma to the tissue. There'll be bleeding beneath that area. Sort of capillaries will leak and blood will leak out. So that's often why an area can become red after an impact, and that can take some time to develop. So it might not be evident immediately. Sometimes it evolves over sort of 1 or 2 days, and will actually develop into a bruise. So just because what I wanted to be clear about really when I was asked specifically about that is that there were no injuries at the time of seeing Nicole Short in terms of bruising to her back, but that's not to say that she couldn't go on to develop bruises.
Can you explain what causes a bruise to happen, to occur?
A force applied an impact of force applied to the tissue will cause bleeding under the tissue into the skin and cause a bruise to develop. So it's blood that will leak out, and when it bruises, it's the blood that's changing colour as the particles are being reabsorbed. So that can take some time. As I say, I'm not an expert. I was asked could I comment on the bruise, and I feel I could, but I'm not an expert in that.
No, that's sufficient for our purposes. Thank you. And can I ask you to comment on paragraphs 88 and 89, please? This relates to loss of consciousness in Nicole Short. And you say you're asked whether you can remember if there was anything to suggest a loss or potential loss of consciousness, and you say you can't comment on that. Certainly if someone's been unconscious, you're not always going to find something a couple of hours later. She did go to the A&E. She was taken to the A&E because of a head injury, or she was taken there to be looked at because there was concern. And she's been seen in the right place in the emergency department, who look at these injuries and injuries all the time, and had no concerns about her. And so you were aware at that time she'd been to the A&E, they'd assessed her for a head injury and discharged her. We understand they'd discharged her with a device in relation to a head injury.
A device? I didn't know about that. But she had told me in the background, as is documented in my written note, that she went to the A&E and they had said that she should be observed, but she wasn't admitted, to my knowledge. And
be observed, does that mean by a member of her friends or family?
That's generally the case. When an individual has had a head injury and is discharged from the A&E, they usually make sure there's someone at home with them.
And so that is the advice that was given by them, and that's normal if you are suspected of having had a head injury.
Oh, I'm sorry. I thought you said they gave her a device. They gave her some advice.
Sorry.
Yeah, that's completely normal. Absolutely.
Right. Sorry, it must just be the connection.
Yeah.
Maybe wasn't quite as good there. No device was given at any time,
No.
as far as I'm aware.
Right. Yeah.
Thank you for clarifying that. Can we look at the next paragraph, please? Paragraph 89. And then you say, sometimes neurological symptoms can evolve. I'm not an expert on this. Sometimes things can evolve over time. There was nothing that I had concern about at that time. If I had, then I would have directed her to the A&E. I would have managed her appropriately. You do that all the time as a GP. If anyone's got any problem with a loss of consciousness, they go straight to the A&E. I'm not going to manage it as a GP. I'm not going to manage it in a police station. She'd be in the A&E, she had gone to the A&E, but I think my understanding from what she said, the A&E said, she just had the observation. When I saw her, the second doctor on the scene, again, I didn't have clinical concern at that time, but things can evolve. So as you note there, neurological symptoms can evolve and things can change over time. But when you saw her at 3:45 on the 3rd of May 2015, you did not have any concerns. And
No
if you
concerns.
had no concerns, and if you had had concerns, you would have sent her straight back to A&E.
Absolutely.
Thank you. I'd like to ask you some further questions in relation to another report, please. So look at paragraph 25 of your inquiry statement, first of all. And do we then see that, then I think after that, I can't recall exactly the timeline, I was again asked by an officer, a detective I think, to examine another individual who'd been with the deceased earlier on in the early hours, I think. I haven't seen those notes that I compiled since then. They'll be with the Orchard Clinic. I was asked to examine them and I think take some swabs or something. Then I went home. So this was a separate individual, a non-police officer, that you were also asked to examine. Can we look, please, at PERC 01319? And I think page 3 again will probably be the start. Do we see that this relates, this is a report by you dated, it says dictated on the 4th of May, and it's dated the 8th of May. And it's in relation to Zahid Saeed, born 1983. Is that correct?
Yep, I can see that, yeah.
And we can see that...
Can I just say, going back to what we said before, sorry, I haven't seen these formal reports for quite some time. In the top right-hand corner there is a date where it is dictated.
I
date
just
we were
noticed
talking
that.
about before. Yeah.
I just noticed
So
that.
that's just to clarify on that.
I've just put a red star around that bit myself. Let's go back to PERC 01310 for the moment and see if we can solve that mystery. So indeed, I should have asked for the screen to be further down. We can see on this one, 01310, it's dictated on the 4th. So it gives date of examination, 3rd of May, dictated on the 4th of May, as you indicated earlier, and then typed, presumably the 7th of May is the date it was typed.
Yeah, so that's the secretary's date, as I said.
So this report, which was prepared on Nicole Short, was dictated the day after the examination.
Yeah,
Thank you.
like it.
Let's go back to PERC 01319, please. And if we could just go up this, thank you. And it says background information from DC Simon Telford. So will this have been the senior officer, detective, or the officer Simon Telford who asked you to carry out this examination?
Yeah, that must be the name of the detective that we alluded to earlier.
Thank you. And can we just read that passage, please, if we come down the screen slightly? The victim, Zaid, was watching a boxing match last night with the deceased Sheku Bayo. They apparently had a few drinks of alcohol, they had an argument, and Zaid parted company with Mr. Bayo. However, he later returned to Mr. Bayo's house. At that point, Zaid reported that Mr. Bayo attacked him and hit him over the head about 5 times. He ran away but was chased, and Mr. Bayo hit him with a whirligig outside in the garden. Zaid went to the A&E in Kirkcaldy at midday for a review. And is that the background information that you received from DC Telford at that time?
Yes.
Thank you. Now, in fairness, we have an inquiry statement from Zaid, which is SBPI 71, and I'll just very briefly show you paragraph 20. And this is a signed statement from Zaid, and paragraph 20 makes it clear that he's talking about his friend Sheku Bayo. And it says, 4th line down, he did throw the washing line pole, but it missed me. I said, Sheik, this is not you. I was shouting that as him. I was shouting, stop, and what are you doing? So thank you, that's fine. If we can go back to PERC 0139, please. So you've been given the information from DC Telford that it was a whirligig. The up-to-date information that the inquiry has appears to be that it was a washing line pole. I don't know if that'll make any difference at all.
I don't know. I mean, I don't really know what a whirligig is. I think it is some sort of laundry device, for washing, for gardens that moves round. But that I was given that information, so
thank you.
It's something I was told.
And do we see that the examination was commenced at 18:30 hours, 6:30? We should have the report back on the screen.
Yeah.
And Zaid had poor eye contact, but his speech was normal, he was quiet, and he was orientated in time, place and person. Now, we may have heard that phrase mentioned previously with other people. What does it mean, orientated in time, place and person?
It's a useful phrase to indicate if there's any concern about confusion. It means that he can give you his name, he knows who he is, he knows where he is, what time it is. He's not confused.
Thank you. And then can we go on to page 4, please? And here you've noted, again, a full body surface examination was conducted and the following injuries were noted. And you've listed 6 injuries that were noted there by you as a result of your examination. And then we see opinion. A bruise is caused by blunt force trauma, such as a knock, blow or pressure on the skin. It will change colour over a passage of time. It can cause swelling. There was no evidence of swelling and tenderness in this gentleman's scalp, which are not showing signs of bruising as yet, but obviously this could change over time. And I think that's consistent with what you've already told us about bruising and how the colour changes and things change over time.
I think you might have read out there was no evidence of swelling. It says there was evidence of swelling.
Sorry, that'll be my mistake. There was evidence of swelling and tenderness in this gentleman's scalp, which are not showing signs of bruising as yet, but obviously this could change over time. Thank you. Sorry, I misread that.
No, that's okay, just to clarify.
And similarly, the swollen area on his face, the maxilla area, may well change and become more discoloured over a period of time and develop into an obvious bruise as the days progress. And is that days as in more than one day?
Yeah, I mean, it can take a couple of days, 1 or 2 days for bruising to really develop, and it can take obviously quite a bit longer for it to fully resolve.
Thank you. And do you say again, this is consistent with trauma. I informed DS Telford of my findings. And then you mention that the forensic samples were taken at the request of CID, and you talk about the various samples that were taken by you during your examination.
Yes.
And then can we just move up? And you then give some general advice about management, and then you have signed that on the 1st of June 2015. Can I go back to the injuries briefly and ask you one or two questions? On page 4, sorry. Here, thank you, that's lovely. You talk about the right maxilla, 2 centimetre swelling, tender on palpation, normal colour, top lip internal laceration, and then you mention right of frenulum. Where's the frenulum?
It's a little tag of tissue of skin beneath the lip in the midline.
Top lip,
Top lip underneath, there's a small piece of tissue there connecting the actual lip to the gum.
thank you. And then there was mention of an injury to the hand, I think. Can you explain to us left hand dorsal aspect, 4 centimetre linear abrasion in the vertical plane, 3 centimetre superior to the third posterior metacarpophalangeal joint. And that's number 5. Can you point out on your own hand where that abrasion was apparent?
Was it the right hand it said?
It says left hand dorsal
Left.
aspect.
It's the back of the hand, sort of just down from the knuckle there.
Thank you.
A few centimetres down and running vertically.
Thank you very much. And then can we go back to your inquiry statement, please? And paragraph 97. I have been asked for my opinion on whether Zaid Saeed's injuries match his account of what had happened in the incident. He's obviously received some trauma to the face, so he could have been hit. That would marry up. He could get injuries from another incident, but if he was hit over the head, he could have some of the injuries that were there. Often you get injuries with the knuckles from punching and fighting, but that's one at the back of the hand. I'm not sure how he's got that. I have been asked if that could have been a defensive injury. It's possible. And so you couldn't find any injuries on his knuckles, which would be indicative of punching or fighting using his hands. Is that correct?
Yeah, that's. I mean, again, this was a long time ago, but that's what's documented in the report.
And the injury on the hand, you've said it's possible that that could have been a defensive injury.
Yeah.
Thank you.
I mean, I was asked that specifically, and I it could be.
Do you know? Can you explain to the people listening what a defensive injury is?
When you're trying to protect yourself, so if you put your arm up over your head, if you're being hit, you're defending yourself.
Mm-hmm. And if you're then struck?
Yes.
Thank you. And then can we look at paragraph 99, please? I've been asked whether there was anything about the fact that Zaid Saeed had been hit potentially in the head with the whirligig. That would you think I had to be a bit careful about his account or how he was feeling, because he might have suffered a head injury. He'd been to the A&E as well. He went to the A&E first. He'd been seen by the experts before I saw him in terms of who should look at his injuries. I don't really feel it's my role. I mean, I'm not taking a police statement, so I didn't have concerns about his neurological status when I saw him in terms of from a medical perspective. My feeling is all about safety and patient safety. If I had concerns, I would send him back to the A&E, but he told me he had been to the A&E. His account helps better direct my examination, but I should still examine everything for completeness anyway. So that's not really something that is part of my role. So again, is this entirely in line with what you've already told us today?
Yeah, I think all I'm saying there is I was asked specifically about, how accurate his account was, and in terms of sort of police evidence, and it's not really my role. I was trying to just clarify my position there was to assess him from a medical perspective.
So you were your focus was about the patient and his medical issues. Yes.
It was.
And then can we look at paragraphs 100, 101 and 102? And you were asked about your involvement with PERC, and that relates to giving your statements to PERC.
Yep.
And you have said that, can we move the screen down, please? And you were working at St Columba's Hospice in Edinburgh at the time when PERC contacted you. This would be in 2018.
Yep.
And you were working there. And you say at 101, I did feel the PERC interview was quite confrontational, if I'm being honest. They were not quite suggesting answers, but it was possibly slightly intimidating. I was under caution, but that's maybe putting it too strongly. I mean, I was quite surprised with the line of questioning. It's not really my role to be cross-examining patients. I'm there in a capacity to do a forensic examination and to assess a patient's well-being, physically and mentally. It's not for me to cross-examine patients. And then at 102, you go on to say, so if I get an account and I have no other suspicion that there's any other concerns regarding their consciousness or neurological status, then I would document it. It's not for me then to say, are you sure nobody's told you that? So it was slightly unusual of PERC to expect that. It's not really for me to then cross-examine a patient, because essentially they're patients of mine at that stage, and I'm making sure they're physically well, being a forensic physician. It's not for me then to doubt what they say. I have to document what they say to help better direct the care given and the examination that I perform, to do as good a job as I can as a forensic physician. And then you go on to say at 103, I was a little bit surprised about the PERC line of questioning about, well, would you have behaved differently if you'd known that she didn't actually recall that someone actually told her that she'd been hit? It wasn't her recollection. This is in relation to Nicole Short. So it's obvious that everyone's treated the same regardless. It's not defined on the history they gave me. It can just help. I was slightly surprised at the line of questioning. And really, I just wanted you to feel that you had an opportunity today to say anything more about the PERC statement that you would like to in relation to these concerns that you've expressed here.
No, I mean, it's perhaps looks like it's put it quite strongly there, and it's certainly not a complaint. But I didn't really see the point of the need for them to come to my work at that stage to do this, to take this additional, this additional statement several years later, and I wasn't really sure of the point of it. As I say, I was just trying to clarify that what my role was, and that hadn't changed. It was to examine and assess the patient from a medical perspective, but not really. It's not really a role for me to then doubt what they say. And I felt that there was suggestion of that in the questioning.
Sorry, I couldn't hear that last part of your answer.
I just felt like there was some element of that when they took the statement. They were specifically focusing on that. So it just was slightly unusual. I felt I didn't understand the point of that additional statement in that interview.
Thank you very much. Could you just give me one moment, please, Dr. Norrie?
Dr. Norrie, can you see me now and hear me again?
Yes, I can.
Yes, thank you. Thank you very much for giving evidence to the inquiry. I'm about to adjourn for arrangements for the next witness to be made, and then somebody will deal with you and bring your link to a close. Thank you very much.
Thank you.
I'll adjourn briefly. Now, Miss Graham, who's the next witness?
The next witness is Mr. Ian Anderson.
Good afternoon, Dr. Anderson.
Good
Will you
afternoon.
take the oath?
Yes.
You just raise your right hand and say the words after me. I swear by Almighty God
I swear by Almighty God,
that I will tell the truth,
I will tell the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Miss Graham.
Thank you. Good afternoon, Mr. Anderson.
Good afternoon.
Good afternoon. You are Ian Anderson,
Yes,
and what age are you?
71.
And I understand you retired in 2011.
No, I retired from the NHS in 2011, but I've been working since in private practice.
And so continuing your work as an expert witness in relation to
In medical legal work, yes.
medical legal work. And you were a consultant in accident and emergency from 1984.
Yes,
And you have an expertise in the initial assessment of head injuries and on the mechanism of injury.
yes,
And you were, for a while, the president of the Royal College of Physicians and Surgeons in Glasgow.
yes,
And you're here today to help the inquiry because you examined Nicole Short on the 21st of May 2015. And that was on the instruction of her solicitor, Peter Watson. And he invited you to give an opinion on the injuries sustained by Nicole Short and her then clinical situation. Is that right?
yes,
And in that regard, you've told us that that was to look for residual physical injuries and any effects of those injuries on her activities of daily living
and employment, yes.
and employment. Thank you. Now, I want to make sure that you have everything you might need today in front of you so that you're comfortable. So, do you see the black folder in front of you?
Yes,
Now, there should be, I think, your inquiry statement there. That's SBPI 00077. Now, you have a hard copy, but when I ask for specific paragraphs, maybe I'll refer you to them. It'll also come up on the screen right in front of you. But when I do that, it might just be the one paragraph that you can see. So if you wish at any time to look through other parts of your inquiry statement, please feel free to do so.
thank you.
And you can just let me know which paragraphs you'd like to refer to.
Yes,
And then in addition, you should have a copy of your medical report on Nicole Short
Yes.
as well. So I want you have hard copies of those, and feel free just to look at them at any time.
thank you.
So let's look first of all then at your inquiry statement, and that's 77. And you'll see it's on the screen, it says Dr. Ian Anderson, and it was taken over FaceTime on Tuesday the 29th of March of this year. And that was someone from the inquiry team was in touch with you and was able to take your statement through the use of technology. I think we were still maybe not quite in lockdown, but there were a lot of restrictions still on the go in March. Is
Yes,
that right?
yes.
And then can we look at the final paragraph, please, which I think is 44. Look at that on the screen. And it says, I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website. And in the knowledge of that, you have then signed your inquiry statement on every page. And I think that may have been done electronically as well. But you have a hard copy, and I only have the redacted copy in front of me.
Yes, it was signed physically by me, actually,
Right,
in the
thank
presence of one of the inquiry's staff.
Thank you. Well, that's excellent.
I'm afraid I'm of an age where I have a healthy disrespect for technology.
I'm exactly the same, but I'm trying to work my way around that. So the signature, we don't see that on the screen, but you have your copy and know that you signed it.
Yes,
And we see that that was on the 6th of May 2022.
yes,
Thank you. And you were doing your best when you gave this statement to the inquiry to be truthful and to be as accurate as you could be.
Given that it had been some considerable number of years before I had compiled the report, yes.
You're not the first witness to have said that. So it's 7 years since you actually looked at or examined Nicole Short.
Yes.
So there may be parts of your statement where you rightly say your recollection's not as clear now as it would have been at the time.
I could tell you that now, yes.
Thank you. That's very helpful, thank you. And then can we look at PERC 01405? So this is the medical report that you prepared on Nicole Short, and we can see that on the screen. And then if we can look to the first page, it was prepared on the 21st of May 2015, and that's your name, Mr. Anderson, and you've given the fact that you're a fellow of various royal colleges,
Yes.
emergency medicine and others. Do you want to tell us about your membership of various royal colleges?
Well, it's at the beginning of the report, and I really don't want to bang the drum about what I did when I was a younger man.
That's very modest of you, but let's look at that for the moment, and just we can see, so for the assistance of the chair, when he comes to consider this at a later time, he can see that you've listed various royal colleges that you're a member of. And as I understand it, when you're made a fellow, that's a more significant status than just being a member.
Yes. It's also more expensive.
I'm sure that's true. Thank you. So when we look at this medical report, it was prepared on the instruction of Peter Watson, who's a solicitor, and it was on behalf of Nicole Short.
Yes.
And she was the patient. And can we look at the last paragraph of the last page, first of all? And we will come back to this, but I just wanted to highlight this paragraph that you've put in your report. And you say, I confirm that insofar as the facts stated in my report are within my knowledge, I have made clear which they are, and I believe them to be true, and that the opinions I have expressed represent my true and complete professional opinion. And so, is it fair to say you're proceeding on the basis that these facts are true, and you say that insofar as the facts stated are within my knowledge, I've made clear which they are, and I believe them to be true. And I think that's the nub of it, isn't it, Mr. Anderson? It's the facts that you had in May 2015. You've noted them in your report, but and I think in paragraph 13 of your inquiry statement, you say that's still a correct statement. You can have a look at that.
Yes.
So your opinion is based on the facts from 2015, and that was the facts that were based on medical records that you'd been sent in relation to Nicole Short,
Yes.
and a history that you took from Nicole Short,
Yes.
and information that was provided to you by her solicitor that was available to the solicitor then.
Yes.
And that was the 21st of May 2015.
Yes.
And am I right in thinking, Mr. Anderson, that that paragraph is there in your medical opinion? Because if the facts change, then your opinion may also change.
Yes.
And you would like the chair presumably to know that if there are different facts available to the chair or new information, some of that may be significant to you and to the opinion that you formed then.
Yes.
Thank you. Now, it will not surprise you to know that as this inquiry has significantly more information at our disposal today than you had on the 21st of May 2015. It's a long period of time. And can I also confirm that when you prepared your report in May 2015, you did not have anything from any other police officers no statements or precognitions or anything like that.
Not that I can remember, no.
And that may be because they did not give statements to PERC until the 4th of June, which was actually after you
Yes.
examined Nicole Short. So none of that information was available to you at the time.
That's correct.
So your report here, you did not take account of any of that. And even since your inquiry statement that we looked at a moment ago, which was taken in March and signed by you in March of this year, even since then, we've taken a number of very detailed statements from eyewitnesses and other witnesses, and we've also taken many hours of oral evidence from witness during the hearings, and none of that would have been available to you at the time.
That's correct.
So none of that would have been available to you. It wasn't available to your patient, Miss Short. It wasn't available to your instructing solicitor, Mr. Watson. And today, I would like to give you an opportunity to consider some of that new information, and if you feel that that is significant to you in your opinion, I would very much like you to tell the chair, because it's important that he understands completely what your views are.
Okay, I
Are you
understand.
happy to go on
Well,
that
I
basis?
understand.
Thank you. That's great. So the other thing, in fairness to you, Mr. Anderson, I'd just like to explain at the outset is that we have another consultant who's coming later after your evidence, and he's also going to hopefully assist the chair. And he was Mr. Rudy Crawford, and he was an accredited specialist in A&E medicine and surgery, and he retired from the NHS in 2016 after more than 37 years in clinical medical practice. And he was 26 years as a consultant at Glasgow Royal Infirmary.
Yes, I know Mr. Crawford
I was
as a
going to
colleague.
ask you.
I don't need any introduction about his background.
I did suspect that you may have.
It's a small church, as you might imagine, and
I can
I was president of what now is the Royal College of Emergency Medicine, of which he's a fellow.
So you do know him, you know of him?
Yes, I do.
Thank you. Now, I will come to this later when we're discussing this, but he had prepared a report for the Crown in August of 2019. It was a desktop report regarding injuries to PC Nicole Short. And he has now given an inquiry statement from May, the 12th of May, and I'll be able to refer you to this later. But I just want you to know this before we start. So he gave a statement in May after you'd given your statement. And some of the information we've been able to provide has now resulted in him changing his opinion. So I'll let you see that as well, so you know. I'm not trying to hide anything from you.
I wouldn't think you would anyway.
No, I'm not doing that. So let's just very briefly go back to your medical report, please. PERC 1405. And you've already told us that page 2 details your appointments. And just in the last couple of minutes, can I ask you, you've been an expert or a skilled witness giving evidence to courts for many years, I imagine.
Yes.
And will that be in criminal cases as well as civil cases?
Yes, both in England and in Scotland.
So throughout the UK,
Yes.
really? And how many reports have you prepared over those years? Are you able to give us any sort of indication?
I suppose they'd be in the thousands now, yes.
And have you prepared many reports for police officers?
Some years ago I did, latterly very few.
Thank you. And would that be both if they were maybe defending criminal allegations, but also if they were pursuing their own civil claims or
Yes,
that type of thing?
that's
So
right.
a variety of different scenarios. And equally, you will have given various reports to non-police officers over the years.
Yes.
Would that be an
Convenient point. Well, we'll stop for lunch and sit at 2 o'clock.